I have the distinct pleasure this morning of being your moderator and in being in conversation, as Ashni has said, with Dr. Niamh Lennox-Chhugani. Niamh is the Chief Executive of the International Foundation for Integrated Care. She has over 30 years experience in evidence-based transformation in healthcare internationally as a clinician, academic, and consultant. Her UK practice experience spans from the early 1990s, where she led the integration of health and education service design and provision for children in the NHS, to her recent work across the last decade, advising on the implementation of new integrated care models in the NHS. Adding to this extensive clinical and academic experience, Niamh also has international policy experience with the World Bank and the WHO, which includes health system policy reform in Europe, Africa, and Asia, and additional work contributing to international health system reviews and integrated care evaluations. While Niamh's expertise is undoubtedly wide-ranging, we have the opportunity today to talk and take a closer look at what it takes to implement successful integrated care programs for older adults. Niamh, thank you so much for joining us today. It's a pleasure to have you. And to kick off today's discussion, I would really love to start with a bit of your own journey, how the many hats you've worn over the years as a clinician, academic, and consultant have brought you to the International Foundation for Integrated Care, and how your background has helped to shape and inform some of this work. Thanks so much for joining us, Niamh.
Thank you so much for that welcome, Anna. And I'm really looking forward to a discussion. So I'll keep my responses relatively brief, because I'm really keen to hear from everybody who's joined the call this morning. So as I think you said in the introduction, I started my career as a clinician. I'm a speech and language pathologist, I think is the terminology that's used in Canada and North America generally, and in most parts of the world. We're speech and language therapists here in the UK and Ireland, and I specialized in pediatrics after a first general year, where I also worked with older adults who were living with the consequences of stroke. But my pediatric journey really started in a growing impatience with working with children and families in isolation in clinics. It made absolutely no sense to me as a speech and language therapist that I was working on a skill that was so central to children's identity and way of life and way of being, and yet I was working in an environment that was completely alien to them. So I worked with commissioners in the area I was in to develop a model of care that looked at embedding speech and language therapists in education and in nursery settings, but also working increasingly in children's homes as well with their families. So that, I would say, back in the early 90s was where my passion for integrating care into the natural context in which people live and work started. And that was hugely successful. It was one of the first models of that kind of care in the UK at the time, and now is mainstream. And I went from there to working in international development, which was a bit of a leap, but still within the context of working with adults and children with long-term disabilities. And again, the way that I was working within a national respite centre that was working with the families of people of all ages living with long-term disabilities in Zimbabwe, in Southern Africa. And again, one of the things I spent most of my time doing was working with the workforce to push out what we were doing into the community, reaching out into communities, working with the families who are using our services to take the kind of capabilities and capacity that we were providing in the centre out into their communities. So again, at every stage in my career, I've tried to ensure that actually we're working with communities and we're working in the places where people live, rather than trying to pull them into a health and care system, which is, you know, for a lot of health and care professionals, a very safe place to be and a very safe place to operate. So I would say that was the early stage of my career, and really that provided the foundations for everything I have done since as a consultant, as an academic, and now in leading the International Foundation for Integrated Care. And I would say many of the principles that I started off with as a pediatric clinician hold true when we're looking at implementing integrated care programs for older people as well. It's what matters to people, what is going to enable them to live the long, healthy lives they want to live in their communities, contributing to their communities.
Thanks so much, Niamh. I think it's such an interesting framing. And it makes me want to get a little bit too, because I think it's certainly for me a very different idea of integrated care than I think we hear frequently. I'm wondering whether we can start with kind of unpacking what integrated care is.
That's a really good question. And it's one that we get asked a lot at the foundation, not surprisingly. Integrated care, I think, has multiple definitions. So I led a project that was funded by the European Commission back in 2016 to 2018. And one of the first deliverables was to define integrated care, and we reviewed how many definitions there were out there. And at the time, there were nearly 200 different definitions of integrated care. So at the foundation, we've stopped trying to define what integrated care is, because integrated care means different things in different contexts. What we do say is that there are 4 really important components to it. One is that it's person-centered, that it's about continuity of care, it's about coordination of care. So continuity and coordination are slightly different. Continuity means over time, coordination is usually across different organizational boundaries, professional boundaries. And then it's about community-centeredness as well. So it's about understanding what matters to the communities in which people live as well. And there can be a narrow interpretation of that. So we can see integrated care being operationalized in single organizational settings. So a hospital trying to integrate services for people better than they currently are. But often integrated care is used within a health system. So trying to integrate services across hospitals, general practitioners, community services. Increasingly, it's used also to bring in social care and social welfare. But then there's an even broader definition that starts to look at how we bring in community sector organizations, bring in things like housing, transport, all of the other wider sectors that affect the environment in which people live and can have a preventative value for people in terms of preventing ill health. So that's a much broader definition. And we would certainly say that there's no right way of doing integrated care. It's very contextual, but it does need to cover those 4 things I talked about: coordination, continuity, person-centeredness, and community-centeredness.
That's great, Niamh. Thank you so much. You've talked a little bit kind of like different contexts, and I think starting your work with pediatrics, obviously, like I think when you think about integrated care, you often think about older people as a population. How does integrated care look different for those populations? And I suppose, how has the approach to integrated care, we talked a little bit last time we spoke about kind of the shift in focus recently around integrated care. So I wonder if you could speak a little bit to that.
So I think, the integrated care as a movement for change started very much with a focus on older people. I think, and many people on the call will recognize this language, but I remember doing my master's back in the late 1990s, early 2000s. And at that point, we were talking about the demographic time bomb was the language that was being used quite extensively at that stage. And it's interesting because I go to conferences where people still talk that language. But I think there was a recognition back in those very early days when the godfather of integrated care, Dennis Codner, wrote his first article in 2000. It was a recognition of that, in inverted commas, demographic time bomb, that actually our health and care systems weren't built to address the needs of the changing population and the changing demography. So that is really, it was older people that integrated care was originally designed to address the needs of. So really, it's that population that has driven the redesign of health and care systems to be more integrated. So a lot of what we see in terms of good practice over the years focuses on that population, and still today, you know, we look at a lot of our health and a lot of the health and care systems that the participants in our movement are working within. Their preoccupation at the moment is how can they better address the needs of older adults who are slipping into health and care crises, and the system is not built to address the needs that they're facing. So I would say that still very much integrated care is focused on the needs of older people. That is changing and has changed over the last 5 years, particularly. I think the pandemic probably shone a light on the fragility of our health and care systems for the whole population, not just older people. So people living, adults and children living with long-term conditions, adults and children with mental health problems. These were two areas that were particularly flagged as not integrated, and therefore very fragile as we went into the pandemic. But even areas like cancer services, increasingly we're seeing submissions to our journal and to our conference from people who are working in the area of cancer care, recognizing that actually cancer services are not integrated, they're not person-centered, they're not coordinated with other health and care services. There is a need, particularly when you're looking at people living with cancer and beyond cancer, to integrate mental health services, to integrate financial support services, employment services. There's a whole range of wraparounds that people are needing to think about for other populations. But without a doubt, there is still a big focus on older people.
Thanks very much, Niamh. I think you've touched on one of the questions that's in the chat, so I'm going to bring Shmuel's question forward. Shmuel attends our Global Café every week, and he always has a great question for us. Today, he's asking a bit about how integrated care programs can support improvement of social and mental resilience of older adults. I think you touched a little bit on how mental health often kind of, I think, slips through the cracks. So I'd love to hear your thoughts on that.
So again, I would say that that's very variable. I think there are some programs that do that really, really well, and those programs that bring in not just mental health services, but also wider community services. So many of the issues we know are around isolation and exclusion from not just health and care services, but from society in general and the way that society operates. So I think there's quite a lot of really good work going on out there, particularly where integrated care programs are bringing in community sector organizations. So civil society organizations are being actively engaged in those programs, and where the communities themselves are being involved in the design of programs. So we've been advising through one of our country hubs, IFIC Ireland, some of the changes that are happening and supporting some of the changes that are happening in Ireland recently. And they have a very active network called Age Friendly Ireland, which I'm sure is part of your network here at the IFA. But they are deeply involved and embedded in the program, the integrated care program for older persons in Ireland. And that, I think, informs very much that approach, much wider approach to mental health and social engagement for older people, as well as focusing on health and care, as important as that is.
Yeah, Age Friendly Ireland is quite unique in their approach there. They've it's a privilege to kind of see grow over the last few years of their age friendly programming. We've got a great kind of question here from Kelly Kay around the how-to of integrated care. Kelly, would you like to come forward and ask your question?
Sure. Thank you very much for your presentation this morning. It's such a great topic. We've been working also, as others on the call have been, in this space, trying to be clear about how to go about the work of integrated care, how to make organizations, trying to tease it out so that people can have a bit of a roadmap. And we still find that often we have to sit with organizational partners and walk them through the process, and simple things like, how about this team member come and work in your team? Like simple things like that. Or how about you put this service over in that organization? How are you going about helping organizations concretely become more integrated or create services that are more integrated?
That's a great question, and there isn't a simple answer to that, Kelly. I wish there was. I think it really depends on the level at which you're working. So quite often the foundation gets pulled in at different levels of systems. So we can get pulled in by a national government to help at a very high level in terms of supporting the strategy and early implementation of projects, and that's quite different from some of the work that we do, where we're supporting independent evaluations of integrated care models on the ground, which I think is more what you're talking about. If I look at that level, I think where we see programs being really successful is where there is they are also very dependent on that very high level. So the most successful programs flourish in a context where there's long-term political commitment to change and delivering new models of care and shifting resources out of hospitals where they traditionally have been very concentrated and investing much more heavily in primary care, in social care, in civil society organizations, in communities, taking a much more asset-based approach to health and well-being, rather than just a focus on curing illness, which has traditionally been much more of a focus of our health systems. So I think that long-term political commitment, and with it comes funding commitment as well, they are pretty fundamental to the long-term success. But I think exactly the strategies you talked about, Kelly, just convening people together in rooms, working together as interdisciplinary teams, having a space, a physical space to work together. So we know from research, co-location of teams is not necessarily the right, it doesn't necessarily answer the challenge of integration, but having a space where you can at least regularly come together and share experiences around how you are supporting people. And those spaces need to include the people who are at the center of care themselves and their caregivers. I think that's one of the biggest cultural challenges that I see for integrated care, is meaningful involvement of people at the center of care and caregivers. That's a shift I don't think we've seen wholeheartedly in any system yet. I think there are systems that aspire to it probably more meaningfully than others, but I think it's a big shift for health and care professionals particularly to make. And it's interesting, we started last year publishing the annual survey on integrated care. And we're just about to publish 2023's, which hopefully will be out soon on our website. But we ask users of services, which are people at the center of care and caregivers, but we also ask health and care professionals, and then we ask policymakers. So we have 3 separate groups we ask the same questions of. And we asked people about their experience of things like care coordination and continuity. And it's really interesting. Users always have a very different perception than health and care professionals. So it's very clear that health and care professionals are not yet really involving carers and people at the center of care fully in their own care, in its planning, in its design, in its delivery. I think that's a big shift that we still have to make.
Thanks for your question, Kelly, and thanks, Niamh, for a great comprehensive answer. My question a little bit is around the idea of the actual the research you do with people, trying to actually engage with patients and get the information you need to kind of inform those programs. What does that look like? You've talked about your survey, which is fantastic, but how do you do that in practice, I guess, and how do the different stakeholders do that meaningfully, as you've said?
So we do our own research, but we also curate other research. So the International Journal of Integrated Care is the journal that we host, and there is a huge volume of research, which is not just academic research, but it's also research in practice that gets published in there. One of the goals that the journal is working towards this year and next is getting much more patient and person-centered involvement in the journal. And one of the things that they're trying to promote is more publication from people with lived experience. So it was one thing we're trying to do as an organization ourselves, that's not necessarily involved in the frontline delivery of integrated care, but at least reflecting the research and practice of it, is trying to get people who are receiving care more involved in the research that is happening. We also try and involve people with lived experience in our international conference on integrated care, in the plenaries that we have at the conference, but also in attending. So we within each week we host our conference in a different city in Europe each year, and we always invite our local partner to bring along people with lived experience and caregivers to the conference, and those places are free, so that we can ensure that we've got people who are the end users, if you like, of integrated care, the people for whom integrated care will have real and meaningful impact, involved in that work. But again, and I'm sure many people on the call will appreciate this, I think researchers still really struggle with how to meaningfully involve people who are in receipt of care in the research that they do. But I think there are more and more researchers out there who recognize that this needs to change and are working hard to make it change.
Yeah, that's fantastic. And I think it's such a good point about that. Co-production needs to start way earlier, I think. I'm curious to know, I think it's great to hear that there's more co-produced research now. And I'm curious to know, especially as a researcher who's kind of traveled that journey yourself, kind of the idea of kind of getting research to practice to policy, that path. How is that changing with, more patient voices being included in research? And how do you ensure that that voice gets injected when the research is not necessarily co-produced?
I think that is a really difficult one. And I think it's a journey that we're all still on. And I don't actually, I say we're all, I think it may be we're all on this call, but I think we might still be in the minority within the research community. I think, you know, and in fact, one of the overarching theme of our conference next year in Belfast is, you know, making it real, making integrated care real, how we move from research to policy to practice, and then the feedback loop back into research and policy. I think it is hugely challenging. I think I suppose for integrated care, in many ways, integrated care has become almost mainstream in many health and care systems. It's become an accepted way of organizing health and care services now. It's a phrase that's used, and there are other synonyms that are used, but it's a phrase that you will commonly see in policy making in almost every country in the world now. So it's how we move from it being a phrase in a policy or a strategy to being meaningfully practiced out there in the world of health and care, and more widely than that. And I think one of the challenges that we face right now is that we are in a place in many of our health and care systems, even in high-income countries, and probably particularly in high-income countries, because we haven't been used to this, in a place of real constraint, because our health and care workforce has been, again, this was another, I remember talking about this in the mid-2000s, the looming health and care workforce crisis. Well, if it was looming in the mid-2000s, here we are in 2023, what did we do about it? I would argue not enough, not nearly enough. In fact, possibly nothing at all. So that I think is one of the key constraints in moving from our ambition and vision for integrated person-centered care to the actual achievement of it. So I think there's a lot of really good things happening out there that we see shared within the journal, in the conferences, in the various events that we put on. But it's not happening quickly enough and at scale sufficiently. And that is because of a whole range of other constraints in our health and care system right now.
Thanks so much, Niamh. Got another great question from Sharon Anderson here. Sharon, would you like to come forward and ask your question?
Hi. First of all, thank you. As a speech language therapist, I know, because I have a husband with aphasia, how important those communities and families are. You can enable or disable. And so integrated care is so important because family caregivers are currently the de facto care coordinators when something happens, and it's the caregiving trajectory is even longer and even more important as we try and download services to communities. Oftentimes it's the invisible family caregivers that are the ones that bear the brunt of that. Yesterday, I was at the Alberta Continuing Care Association conference. The keynotes, the last speech was absolutely wonderful. Thanked everyone else. And even though throughout the conference, they talked about how important family caregivers were to moving integrated care services to the community, he thanked everybody else, and family caregivers were not included. So how do we start to make sure that family caregivers are explicitly included in those care pathways? You know, so if you're talking about hospital to hospital or home to hospital to wherever, you know, or the acute care bundles, how we treat those chronic disease pathways, how do we include those family caregivers? How do we make that policy?
Thanks so much, Sharon. Niamh, a big question.
That is a really good question. And I think there are different ways of tackling that, and we see that in different countries. So a really good example of one way to tackle that is in Germany, where Germany actually has in law specific support for family caregivers. So their funding system, they have a social insurance system, and part of the social insurance system includes financial support for family caregivers to provide exactly what you're talking about, Sharon, that care coordination that they recognize that family caregivers do. And they also acknowledge the fact that for family caregivers, it often means they're having to give up paid employment as well in order to fulfill that role. So Germany have taken a very practical view on that, and I think that is probably something most other countries, if not all, need to emulate. It's recognizing that actually the cost to families of providing care coordination is huge, and I think there's a language that's used around caregivers in many health and care systems that assumes that they are a resource that is available for free, and that because there's no cost to the system, therefore it is cost free. And of course, the cost to families is huge. And we're not just talking monetary cost, we're talking about emotional burden, as well as very practical time costs as well. And they're costs that most families willingly give to care for a loved one, but nonetheless, that needs to be acknowledged. And I think that is something that the foundation are working with WHO Europe at the moment on a paper that we hope to produce next year around integrated long-term care. And obviously a lot of that is focused on older people. And one of the areas we're particularly focusing on is trying to find examples where there is explicit support for family caregivers, recognizing actually that without family caregivers, we don't have integrated long-term care. We don't have long-term care, full stop. It doesn't exist without family caregivers.
Thanks so much, Niamh. Thank you so much, Sharon, for a really important question. We've got another interesting question, and it kind of speaks to, I think, that cost aspect a little bit, Niamh. Amara Francis, would you like to come forward and ask your question? Give her a moment. Sometimes the mics take a while to turn on. If not, I can ask.
Hello, can you hear me?
Yes, we can hear you.
Sorry, I'm unable to put up my video because of where I am right now.
That's okay.
But my question is straight up, and it's on making it practical. We know the benefits of the strategies of funding preventive and public health programs that are out of hospital-based approach. But the question is, there are people that actually make the money decisions, not necessarily us in the field doing these practical works and the community-based projects. How do we get not just the policymakers, but those that make the money decisions? I will call them that because they are just vast. How do we get them to understand the benefits of the integrated care in the community-based approach as against the hospital-based approach? Maybe if you could cite an example of how you probably have done that in the past, it will help us. I'm from Nigeria and working with Mission to Elderly's Foundation. Thank you.
Thanks so much, Amara. Niamh.
I think that's a great question. And again, one we get asked a lot. How do we make the case for integrated community-based care? I would signpost Amara and others to a project called Transform, which I'll send the link to Anna and Ashni afterwards. But it was a number of European foundations came together to identify projects that were doing exactly that, trying to make the case for integrated community-driven care for people. But it is a really difficult question to answer. What I would say is we know from the evidence already, if we think about the quadruple aim of health and care systems as being focused on better health outcomes, better experience of care for the individual, better staff satisfaction, and better value for money, we already know from the evidence that you do get better clinical outcomes, certainly in terms of morbidity, by implementing integrated care that is less focused on hospital interventions. Mortality, not surprisingly, we don't see necessarily a huge effect, if any, and that's because of the population that we're talking about. What we also see is that there is a marked increase in satisfaction and experience of care from people who are receiving integrated person-centered care. We also know that staff feel more satisfied and are more likely to stay in their roles if they're working in interdisciplinary teams that are focused on meeting the needs of people in a person-centered way. There is now much more evidence around value. So actually the value to a whole health system of delivering integrated care is now being demonstrated. So we are starting to see that if you take health and care downstream, to use one of those words that people often do in policymaking, so taking it out of hospital, making it less focused on curative care and more focused on prevention. And it's not just public health, but secondary prevention, so putting more resources into primary care to identify people with potentially high levels of healthcare need who might go into crisis, and preventing that crisis from happening in the first place. We do know that actually that delivers you much better value for money. May not save you money. That's where the issue has always been, this assumption that integrated care is going to save a health system money. Actually, we don't really have the evidence to show that it does, because A, you need to invest more. You just need to move money from one part of the system, but you need to put it in the other. And you also, but what you do is you ensure that what you're getting for that money is much higher value, because you are improving outcomes for people and you are improving their experience of care. So that would always be the case for why this is the right thing to do.
Thanks, Niamh. It makes me think a little bit about kind of the challenges of evaluation in the context of kind of that public health paradox. When you're preventing something, how can you measure? So I wonder whether you could speak a little bit to just kind of the importance of evaluation in the context of integrated care, and how evaluation differs in this context.
So evaluation is hugely important. Evaluation is hugely important in where you're making any change in any case, because it's, particularly embedded evaluation. And I think this is something actually that, Ontario health teams in Canada are a really good example of doing well. The investment that has been made in Ontario in embedding what they call the Ontario Health Fellows, health team fellows, who are embedded researchers who are working within teams in Ontario to really work with the teams to research and understand what difference they're making, what change is being made, and measuring that change. I think that's a really good example of a system that understands the value of ongoing monitoring and evaluation to understand the effect that you're having, and feed that back into a learning system. So I think it is hugely important. Having said that, integrated care, because of the fact that it is a large and often complex intervention, and because it's not one thing, it's a lot of things tied together in organizing a system in a different way, it can be quite challenging to evaluate, because, attribution is a real issue in evaluating integrated care. It's often quite difficult to say, well, we changed this one thing, and because of that one thing, all of these things happened, because usually you're changing multiple things. And it can be quite difficult to attribute. However, having said that, we use a model that we call theory of change, which is actually a really good way of getting people together, including people at the center of care and caregivers and communities, into a room to have a conversation about what are we doing differently from what has happened before? What do we think the effect of that will be? And how are we going to measure it together? And just having that conversation as part of an evaluation can be hugely powerful.
Yeah. So again, Niamh, I think you've talked about kind of the importance of having, again, that patient voice in the process of developing evaluation plans in the beginning, which I think is great. I want to switch tracks a little bit because I think for me, you've touched on a really interesting point, which is kind of the complexity of integrated care. And obviously integrated care is wide range. It can look different in different contexts. How do you think that complexity, because I see it a little bit similar to long-term care. I think there's a global definition of long-term care, and then there's a definition in different countries, and that can lead to a lot of confusion often. So to what degree has kind of the broad definition or kind of lack of hard definition on integrated care created challenges in working internationally or kind of working in different contexts and trying to get people, even policymakers, on the same page with what this means and what it is?
I think it is a big part of the problem of why convincing policymakers that this is the right thing to do is so challenging. But I think it's a bit of a deficit model, which I'm not a fan of, but sometimes with policymakers, what you need to do is just put in front of them the fact that what you've currently got is not working. So we all accept that where our health and care systems are today is not working for us, and it's not working for the system either. And really the pandemic was a wake-up call to that really our systems were not fit for purpose. So that's the starting point. I think, I have a colleague, the chair of our board, Professor Anya Carroll, whose main research interest is complexity in the context of integrated care. So she would probably answer this question. First of all, she'd hugely enjoy this question, and she'd maybe answer it in a slightly different way. But when Anya and I talk about complexity, again, it's where this theory of change and having the conversation around your specific theory of change. What is it that you think an approach to care integration, what difference do you think it's going to make? What problem is it solving in your system at this point in time? And why do you think it's going to have that effect? And then being clear about how you're going to measure it. So I think one of the challenges there is often trying to align different stakeholders' views, because coming back to the point we were talking earlier about, I think Amara was talking about the power differential between hospitals and everyone else in health and care systems. If you've got a system that is being driven by trying to save money for the hospital or reduce emergency department attendance or emergency admissions through the ED attendance, then that's going to drive your model of integrated care in a very different way from a model that's coming from a community that says, actually, we want to keep people out of hospital because actually we think that we have the assets within our community to look after each other better. And we want to be working more closely with our community workers, with our primary care practitioners, with our other community services to create much better conditions for people to live and work in. And that's going to stop people needing the emergency department so much. So it is complicated, but actually it's about having local conversations about what's meaningful to you.
Thanks so much, Niamh. Have had another comment from Sharon, which I think is really interesting. And it's the idea of kind of, I think we talk a lot now that there's a shift to talk about patient-centered care and the kind of patient voice within care. To what degree do you see that as an opportunity for kind of better inclusion of caregiver voices? And to what degree do you see that as saying, oh, you fixed the problem, we're focusing on patient voices, the caregivers will trickle through? Kind of, do you see a bit of a dissonance there, or how do you see that kind of playing out in practice?
Oh, I think there is a huge dissonance there. And I think it's not a lack of will. I think people genuinely do want to include, but actually, if you look at the way incentives work for policymakers and senior decision makers in our health and care systems, they don't drive the kind of behavior that we want to see in that. So I think it is a huge challenge. And I think it comes back again to that whole control of resources dynamic that we have in our health and care systems. I think, and I see a lot of the push for that change coming from patient and carers organizations who are becoming much more vocal and militant, which I am completely supportive of, about putting in front of policymakers the value of their contribution, particularly in the case of long-term care, and the fact that they're shouldering a burden that is being taken off the state at the moment. So I think there is a bit of a shift. I think we clearly have a very long way to go, but I think there's much they're pushing, those organizations are now pushing at a much more open door than they might have done in the past. Our task in the next years really is to look at the incentives in our systems to create the conditions for that to really happen, and open that door completely.
Thanks very much, Niamh. I think one of the questions I have, and it might be, again, too hard of a question to answer in a lot of ways, but I think, again, we talked about, obviously, the complexity of working with integrated care systems is vast, but what would you say is some kind of low-hanging fruit that, if you were kind of an entry point for people looking to kind of improve their systems, but maybe don't have, whether it's the resources or budget to kind of do the massive overhaul or kind of the work that it changes to kind of do that whole system redesign. What would you kind of recommend for people as kind of an entry point to making some change, positive change?
So I think one really concrete example is around continuity of care. So it is something that single organizations can do. You don't even need to have to engage necessarily more widely in the system. I read a paper that's it's not been peer reviewed yet, but it's on the SSRN, which is the open access research website. But it's a paper that's been written by some researchers from Cambridge University and INSEAD in France, where they took NHS England data and looked at what would be the effect of a general practitioner seeing the same person. So a person, instead of seeing multiple practitioners every time they go into their primary care practice, seeing a named practitioner and seeing the same person every time. And what they found, really interestingly, so they had a lot of longitudinal data, and what they found is actually it saves time in the practice. There is a much longer period of time, and they were looking mostly at older people and people living with long-term conditions. They found there was a much longer period between each appointment for people who had continuity of care than people who didn't. So effectively, they were saving quite a lot of appointment time by a person seeing their named physician. And I think those sort of things, we have quite a lot of evidence around care continuity now, that it saves time, it reduces clinical risk, particularly around prescribing errors, and it also gives a person a much better experience of care. So for older people and people living with long-term conditions, I think that is a really good, tangible starting point that also doesn't necessarily mean you need to have more resources and more money. It's just it's a different way of working.
Yeah, absolutely. Thanks so much, Niamh. I'm going to come back again. I kind of talked about data a couple of times now, and I'm wondering, more of just a curiosity almost. We know that data, and certainly kind of good age disaggregated data, there's a huge paucity of it. Kind of to what degree is the the center kind of helping to kind of create more data? And I guess, how do you deal with the lack of good data in kind of driving your programs, which I know are very evidence-based?
So we don't, because we're collating the evidence from other systems, we don't necessarily directly access the data unless we're doing an evaluation. And even then, generally speaking, we will take a facilitative role, because what we aim to do is enable a system to do its own evaluation with support from us. What I would say around data is that a lot of systems have a long history of collecting certain sets of data in certain ways. And what systems find it really difficult to do is to let go of that. Even when that data is no longer relevant, no longer tells them anything useful whatsoever, they still can't stop collecting it for some reason. So one of the first things we will often do when we go in is look at data and go, well, why? Asking questions on, why are you still collecting this? What value is it adding? What does it tell you? How does it inform decision making? I can't honestly say that we get a response who says, oh yeah, that's a really good idea, maybe we should stop collecting it. That almost never happens. Because somebody somewhere will have a job that's about collecting and sorting through that data. But I think there is a growing recognition, though, that we need to start reframing the data that we're collecting and what we're using it to do. So building in much better feedback loops. I think one of the biggest gaps we still have in most systems is around patient-reported outcomes. So we still have very few, if any, systems that are systematically collecting data directly from patients around their own reported outcomes. And that is a shift that we have to see, and we have to see it pretty quickly, because if we're saying our health and care systems are all about improving the person's experience, then we should be measuring that.
Yeah, absolutely. That's a great point, Niamh. I want to expand a little bit. I think you brought up a really interesting point, which is how we frame the data is important as the data itself. So I'm curious to kind of unpack that a little further. What do you mean by that? And what does that look like? Kind of framing that data in a different way.
So framing the data, I suppose, is about, what are we using the data to do? What decisions is it driving? And what is that feedback loop into the system? And there are different layers, obviously, of data requirements. So what policymakers need at a national or regional level looks quite different from what health and care professionals at the front line working with families and communities need to drive clinical decision-making at the front line, clinical and care decision-making. But there should be a link between the two, and I think that's not always very clear. There are some systems, so again, I would come back to systems like Ireland, who are in the process of redesigning the data that they collect, and in many ways they're quite they're in a relatively good place because they don't have a huge amount of data they've already been collecting. So in a way, they have a much more blank sheet of paper. In the NHS, in the 4 countries in the UK, it's the opposite problem. They have a huge amount of data they've been collecting for a long time and are now trying to adjust the data to support decision-making in integrated care systems rather than in separate organizations. And that is a huge challenge, and one they've been trying to work on for a decade. And they're still not quite there yet. They're getting there, but they're not quite there yet. And then you look at systems like the Netherlands, like Germany, but their systems were built very similarly to the US, actually, because they're actually around billing. Their information systems were designed to be able to bill people or to account back to their health insurance.
Very patient-centered.
Yeah, so it's what did we originally design our systems to do, and how do we change that? Is actually, that's what I'm talking about, framing. That framing is that's a big challenge.
Absolutely. Well, I'm always surprised at how quickly we come to the hour, and it's gone by very fast today, Niamh. It's been such a great dynamic discussion. I'm going to take the time to introduce our next speaker and give you a few moments, Niamh, because we're going to come back to you for some key takeaways. But in the meantime, I hope all of you will join us next week. We have a great speaker coming, Miss Christina Fazer.